you, Michelle. So I am the last leg of the QI program this morning, and I'm going to switch gears a little bit and talk about psychosocial care in pediatric IBD. And I am a pediatric person, so I'm really happy to see that there's so many pediatric people here this morning. And I really wanted to start today talking about why it was so important, I thought, to talk about psychosocial care today, whether you're in pediatrics or the adult arena. And several reasons, but one of the main reasons was my patient that I'll talk about in a few minutes, who I'm doing the case study on. I thought I was doing a good job of psychosocial care. We weren't doing any formal screening in our clinic, but I thought I spent enough time and asked enough questions that I was getting the information that I needed. After seeing this patient, and this was about a year ago, I realized I wasn't doing such a great job. So I'm going to try to share some of that with you. The second part of it is we hear an awful lot about we don't have the resources needed to be able to do any kind of psychosocial screening. We don't have a social worker. We don't have dedicated psychology. At our center, we do not, and that made it more difficult, but that should not be a complete stumbling block against doing it. And actually, a physician said that yesterday to me. We don't do any psychosocial screening because we don't have a social worker, nor do we have a psychologist. So I'll try to kind of explain how we worked it out, and you might have many more resources than we do, in which case it'll be a whole lot easier for you than it may be for some other people. So objectives, we're just going to talk about some of the psychosocial concerns. I'm really going to focus on depression mainly because in a 20-minute talk you really can't go through everything, and my particular patient had depressive symptoms, and that's going to be kind of the focus today. I'm also going to talk about specific tools that can be used not only for assessing depression but also just general quality of life issues. So why do we need it? Pam already talked about it. Everybody's already mentioned it. We really want to decrease variation in care. So Dr. Bob and nurse practitioner Betty were giving different care, right? Well, we do the same thing with psychosocial care. It's really important to be thinking about this. We really want to think about how can we improve the quality of life for our patients so that they can do what they need to do on any given day. And it's important to have screening tools to assess. So, why do we need it? We know there's depression, anxiety, concerns about quality of life issues, social isolation. We know about 25% of adolescent patients are going to show symptoms of depression. And 97% of those patients will be missed if we don't specifically ask. So that's where I got into trouble. We know that depression is linked to pain, diarrhea, weight loss, and elevated SED rate. And we know, in general, those who have more severe disease course are going to be more likely to be depressed. Those with inactive disease or mild disease can be compared to the healthy child, but the ones with the more severe disease course are going to be more likely to be depressed. So quality of life issues, social interactions are impaired in a fair number of these patients. We know that affects healthcare utilization, so increased ER visits, increased hospitalizations, increased telephone calls to the practice because they're having difficulty. We also know that they have poor school function. Attendance can be a huge problem. Grades can be a problem. So we know that we can affect clinical outcome by appropriate screening and appropriate treatment. And if we are treating depression, hopefully our patients will be more adherent, which will improve their outcome. We want to make sure that if we're doing this screening, we have a mechanism for making referrals, and I'll talk a little bit about that in a few minutes. So what are specific issues facing children and teens with IBD? And when I was trying to think about how to express my thoughts on this slide, I really thought about a patient that I first saw as a new patient, came in with a diagnosis of failure to thrive 3 months ago. And she went from a child who came in to see us with some vague abdominal issues, but mostly growth issues. And in 3 months' time, I'll tell you how her course has gone. She is 12 years old. She looks like she's about 7 or 8. Very, very growth delayed. She initially came in, she got labs done, she had stool studies done, she had a bone age done. Bone age was 3.5 years delayed. From there, she had an upper endoscopy and a colonoscopy. It didn't show as much disease as she was so significantly stunted. We sent her to endocrine, nothing unusual came up there. So then she had a capsule endoscopy. We got a little more information, but again, we were expecting much more severe disease for how stunted her growth was. She then had a balloon enteroscopy, which finally showed us that she had pretty significant chronic inflammation in her jejunum. And so we tried to do enteral therapy. We wanted to do exclusive enteral nutrition on her. And they tried to do it orally, and it was very, very difficult for her. She absolutely, adamantly refused to have an NG tube permanently, but she agreed to have an NG tube to see how she'd tolerate it. She then had NG tube feedings, which she tolerated well, and had a G tube placed. That's all in 3 months' time. So you can see what she had to deal with. So she's now on azathioprine with 90% exclusive enteral nutrition through her G-tube. She had the G-tube a couple of weeks ago. She's home now, but she asked for a pass from gym. Number one, she's in 6th grade. Everybody dresses out for gym. She didn't want anybody to see her. Plus, she doesn't look like a average sixth grader. So she really, it's affecting her whole life and her social interactions. As well as her body image. She has some disordered eating, not your typical patient that you would think of, but she's never really liked to eat, and you wonder how long she didn't feel well and wasn't able to eat. So this is a very typical, a very atypical scenario, but it just goes to show how difficult it can be for some of these kids and the issues that they suffer from. All right, so now I have to ask the question, how many of you are doing formal psychosocial assessment in your practices? Big hands, high hands, okay. A few, right? Okay. And those of you who are assessing, what are you assessing? You can just shout out. It's over in that area. Okay. Anybody do anything besides the PEDS quality of life?
Our social workers doing the psychosocial assessment tool on newly diagnosed patients when we can.
Okay. Was that when you can? Okay.
Try.
Okay.
It's not always successful.
Okay. Anybody have anything different? Yes. Okay. So not a lot, and that's sort of where we were. And so you have to think about what is it you want to assess, how are you going to do it, how often are you going to do it, are you going to do it with pen and paper, do you have access to iPads where they could be sitting in the waiting area and do it, and then how are you tracking it? And once you get that information, say you find a patient is depressed, you have to do something about it. So how does that all work? And so really, what is it you want to assess? You want to really look at the health-related quality of life. And when you do so, you're looking at depression, anxiety, how do they function socially? That child I just talked about was not functioning normally socially. How are they functioning in school? Are they going to school? How does their family function? Is the family adjusting to the diagnosis and dealing with in a child who might be having relapses? And then lastly, adherence and self-management. Are they able to do what they're supposed to be doing in terms of taking their medications? And you might have formal screening. A lot of people in pediatrics have adapted the Mirsky modified scale that has 8 questions, but you don't have to actually do formal screening. You can take some of the questions from that and do adherence screening. And you all know that if you ask a patient, do you take your medication daily? What is the answer they're going to give you? Yes, because that's what's expected, right? But there's other ways to ask some of the questions from the modified Mirsky scale that get at that same information. In the past 2 weeks, how many days have you taken your medication? So even if you don't do formal screening in that area, it can be bits and pieces to help you get that information. And then lastly, self-management. And that people really struggle with because they think of it as a huge time sink and trying to get these kids to take care of themselves. But there's ways to go about doing that if you start at an early age, the 12 to 14 age group, and sort of work along the continuum with things they need to know, hopefully by the time they get to the adult world. And I say hopefully because we know that doesn't always happen. They are doing what they need to be doing most of the time to take care of themselves. So this comes to my case study, and it was an interesting situation because this was a girl who would come to clinic. She always looked happy, always had a smile on her face. The nurses loved her and always commented on how happy she was. Pleasant and interactive. She had some recent problems with her Crohn's. And the one thing that was a little bit of a red flag in my mind was she always said she hated school. Always. Never happy about school. So they would go to the Jersey Shore every summer with extended family, and she apparently was having some trouble when she was there over the summer. But this whole scenario didn't really start until October, so a couple of months had gone by at least where she was having these symptoms. And so what happened was Mom said, she's expressed, concerns about suicidal ideation. And so we got her in very quickly the next day with our psychologist. And our psychologist felt very concerned about how she was doing. Low mood, crying, was very upset. So she had a recent suicide intervention at school, and she learned about depression, heard stories about kids that had committed suicide. So she started having what they call passive suicidal ideation. So she had a history of sleepwalking, and so she had nightmares that she would get up in the middle of the night, tie socks together, and jump off of her dresser and hang herself. So it wasn't, your typical suicidal ideation, but it was pretty significant concern to her. She had also stepped up therapy recently, and she worried she was going to overdose on IV medications. There was no active suicidal ideation or self-injurious behavior noted by the psychologist. So this psychologist came up with a very good plan for her. These are pretty typical. She wanted to keep her away from any medication. She didn't want her to be by herself. The patient and the mother refused to take any kind of medication, and they were really against hospitalization, as you can well imagine. She gave her some coping strategies, including guided imagery and cognitive behavioral therapy, and then brought her back in a week. She did fairly well. She saw her regularly for a while, and then finally she decided that she didn't feel like she needed to go anymore, and Mom decided that she didn't feel like she needed to go either. But I'll talk about her more in just a minute. So that brings me to how do we assess psychosocial status? And really what was kind of gnawing at my craw was you ask the patient how they're feeling. Are you feeling well, yes or no? Ask them about their activity level, and they'll tell you, I'm doing, cross country, and I'm running every day, or I'm not doing any activities. And you try to sort out whether that means something different for them or not. And then lastly, we're told to assess psychosocial risk factors that significantly impact the patient's medical care. Well, what does that mean, really? That's kind of a subjective thing, and we've talked about it in our ICN pediatric group as to what does that mean, and it means different things to different people. Like for an adolescent who's smoking, that's a psychosocial factor that affects their medical care, but some of the other factors are a little bit tougher to tease out. So one of the things, we talk about a lot in QI is doing a PDSA cycle. And so really, what is it you want to change? Make plans for that change, try it out, analyze it, and then what is going to change based on that? So for a long time, I had been thinking about how we could do this, and I talked to Mike Kappelman, who is big in the area of QI, who is one of the attendings that I work closely with, and we decided that we would start screening for depression, not quality of life. And the reason we decided to do this was because this tool was free, easy to do, easy to score. We didn't need psychology's help in doing it. So really, we wanted to be able to identify these patients, and we wanted to be able to link them to the appropriate referral. And there are different, like if you Google PHQ-9, there's some variations in the form, but this is the modified adolescent PHQ-9, and so it has some questions at the bottom that really address suicidal risk, and so that's really nice. So the two of us, over a period of a month, administered the modified PHQ-9 during routine visits for our patients 12 and up. We reviewed the results with the patient and the family at the visit. We referred them as needed, and then are following up either sooner or at the next visit. So interestingly enough, if you look at 25% of our patients, pediatric patients, are depressed, we only screened 20 patients, and again, this was kind of a pilot study. Most of them were female, most of them had Crohn's disease. What we found was 45% of them had some degree of depression, and so we were kind of surprised that we were kind of way over what we expected to get. And so then I sort of looked further and said, well, they say that the more significant the disease, the more likely they are to have depression. So I went and tracked physician global assessment on those 20 patients that we had done. And interestingly enough, 12 of them had inactive disease, 5 of them had mild disease, and 3 of them had moderate disease. So really, we didn't have anybody in the severe category, and nobody was really sick. So then what I did was I tracked it back, and several of them that were at the upper level were kids who had had a pretty significant disease course, even though they happened to be mild or inactive at this time. So I think what I learned was even if you don't happen to be real sick at the time, you have to think about what they've been through. And one of the patients that screened positive was that patient who is newly diagnosed, who's been through everything, including a G-tube, in 3 months' time. So that makes sense to me. So, what do we do? Well, we've anybody that's screened positive, there's further screening that we do. I didn't mention before, one of the reasons we use the modified PHQ-9 is our general peds people are using it, and so they had already developed an algorithm. If you score this, then you do this, and it kind of gave us a nice way to move forward. Refer to mental health professional if you don't have really good psychology support in your practice. Can be difficult, and so what we had to do was we had to actually compile a a list of providers all over the state, because we have patients coming from all over the state, for all the different insurances that we have. And that was a bit of an undertaking. But we've got that now, which we should have had before, and we didn't. So cognitive behavioral therapy works really well in the adolescent patient because they don't have the ingrained kinds of behaviors that adults have in a lot of cases. We sometimes use hypnosis, medications, and then some of the other support groups, really looking at family functioning because that has a role as well. Trying to improve their social network, which Camp Oasis works great for. And then if they're having school issues, do they have a 504 plan in place for accommodations? And if not, how can we help them do that? So just take-home messages, you really need to look at, is the child having distress right now, or is this a long-term problem? The only way to know that is to assess it. How often should you assess it? You know, at least yearly, or any time there's a change in disease status where you think you might need to assess it. You want to really assess multiple areas. So we're really only looking at depression right now because it was a very quick, cheap, easy thing to do. But we know we need to look at other areas. Somehow come up with some form of assessment, look at family coping, and then you have to provide the support and resources for them.